connected to our community for more than 5 minutes. You've worked with him or heard of him, Dr. Zolek.
So I can actually add, before I start the talk, on what this discussion was about. So we had in the Mayo Clinic Tapestry study, which we examined 100,000 patients with exome sequencing. Those are different Mayo Clinic patients, different diagnoses. And we found 28 variants in this cohort. None of them had CSF1R related disease. We don't have a permission to go to the charts and check if they later develop disease or not, because due to the ethical reasons. But it tells you about the penetrance, that in real life, rather than in brain bank, which is already skewed for the patient supporting the research, right? So this one is also skewed to the patients reported the research, but that was opportunistic cohort. So we are going to publish this. We have actually paper submitted on this. So that is additional things, that the penetrance of many of these variants may be much, much reduced. And I'm going to touch why, one of the reasons why it is in my talk. So thank you, the organizers, for inviting me, particularly Dr. Sullivan, Mrs. Sullivan, as well as the UFL for organizing this symposium. So here are the conflict of interest, and many things that I have done for this disease was not sponsored by any grants that I had over the years. As a matter of fact, that was a spin from other grants that I had. But lately, I have been very lucky to be sponsored by pharma, including Savannah. So what is the most important unmet need for you? Of course, we need to find the treatment. And how we can get to this point, to find the treatment? Well, we need to have a correct diagnosis, and we have good diagnostic criteria. We have to have enough patients who will be willing to undergo an experimental treatment. We need to select patients in the right stage of the illness, and we have to have reliable, specific, and validated clinical scales to measure the outcomes, and we have to have reliable biomarkers. So in order to get to this point, we have to do preclinical studies, and this is what Dr. Spitale was actually talking about, and that's very important what Dr. Chatavarian is doing. So those are the preclinical studies, and over the last 2 or 3 years, we have made significant progress on understanding of CSF1R related disorder. And we have to have a clinical studies. And here I have a good news for you. Natural history study that was sponsored by Vigil was accepted by Brain Communications last week. And this is a legacy of Vigil, because first it organized the community, provide funding for organizational efforts, and also did the natural history. They needed this natural history study in order to document the effects of their phase 2 trial, because that was not placebo-controlled study. So they needed that for the commercial reasons, but that is their legacy that will last for a very long time. So that is a major achievement thanks to Vigil and his employees. So preclinical studies, I'm not going to spend much time on this, that was discussed, but we have very good studies, and Dr. Chatavarian discussed that. So the clinical studies, Vigil was phase 2 trial at less than 100 participants, and we hope that we'll have soon another phase 2 trial, perhaps through the efforts of Savannah. Now, what was the failure that Vigil did. I was helping them from the beginning. I was involved in their efforts in building the protocols, etc. Unfortunately, this was devastating for our community. The trial was stopped exactly a year ago on June 4th of 2025. It was not successful. But what we can learn from this trial, this is not going to be published. It's going to be, was published only in the abstract form, and Vigil decided not to publish the data. But what was wrong with this trial, and what we need to do to remedy these deficiencies? The first one, and the most important problem with the trial, was that was no fully supported experimental understanding. The mechanistic understanding of this trial was very simplistic. We stimulate one gene, TREM2, which is a major risk factor for Alzheimer's disease, and this is why Vigil was interested in this, because they wanted to go to the Alzheimer's trial. So stimulation of TREM2 stimulated the CSF1R gene. Upregulation of this gene produced more protein, CSF1R protein, and then a loss of function that is in this disease will be repaired and everything will return to normal. So there are many simple steps in between, and as a matter of fact, now there is an emerging evidence that not stimulation or agonism of TREM2 is a good way, but antagonism, just reduction of the TREM2 is probably the way to go. So as you can see, the entire trial was based probably on insufficient mechanistic understanding of this function of CSF1R and TREM2 genes. There was no well-defined stages of the illness. There was no, the patients were not enrolled in the most optimal stage. They had very simplistic one, preclinical or clinical. There was no differences. So many patients were enrolled that probably should not be enrolled in this study. They have no validated clinical scales. We borrow those scales from other diseases, of corticobasal degeneration, from frontotemporal dementia, from Parkinson's disease, from other illnesses. There was only one validated radiological scale, that Sundal scale, that my former fellow developed some years ago. But the volumetric studies, which are more run by machine, was actually part as a secondary game, secondary aim of the study. There was no use of biomarkers. As a matter of fact, their use, again, the exploratory aim was to check the biomarkers. And perhaps there were too many centers. There were some centers that don't enroll any patient. There were some centers that enroll only one patient. So that was also the problem of the study, introducing variability in recruitment and assessment. So what has been accomplished since Vigil trial discontinuation? So over the last 2 years, we and others concentrated to develop tools. So the next trial will have better chance to be successful. So correct diagnosis, you heard from Dr. Lee, genetic testing, there's lots of problems with this, but we have commercial genetic testing widely available. So that's the first step, and this is widely available. Almost all commercial companies have this testing available right now. So this is, we are in good shape here. We have enough patients. Well, this is the support groups coming. So Vigil was able to energize all of you. So that is wonderful that we have right now the support groups, and we have community that when the next trial will come, we will have the patients will be notified quickly and will be able to participate in the trial. Now, we develop a staging system, and Dr. Spitale was part of that, and he actually stimulated us to develop that. We have right now a staging system that will be very precise, so we know what kind of patients we want to enroll in the trial. Now, we have developed a clinical scale, a scale that is specific for CSF1R. We don't need to borrow the clinical scales from other conditions. We have validated scale right now. So we have volumetric studies done, VIGIL, and we have another paper coming on MRI volumetric studies. So that is another more precise way to measure the outcomes of the potential trial. And we have right now reliable biofluid readouts. And again, that is thanks to VIGIL and to Savannah, that we know right now that they are very good biofluid readouts, and that will be helpful as well. So from the beginning, we know that will be very diversified situation here. We have 14 families participated in the gene discovery, and we had 14 mutations. So Dr. Lee right now showed you there is more than 400 of these mutations. But from the beginning, this was obvious. I studied many other diseases. Parkinson's disease, for example, due to VPS 35. It's just only one mutation. And we discovered this gene, 20 years ago. And it still is only one mutation. But here you have just opposite. We have 460 mutations she showed you. So that is the challenge, but it's also good that we have this option of having the genetic analysis. Without genetic analysis, we will not be here. So she talked about the penetrance. Well, this is the answer why this is one of the answers why some of the mutations may have a different penetrance. So over the last few years, we were able to find out that some of the mutations are very aggressive. We have just recently had a paper with a patient who survived only 10 months from the onset to death. On the other side of the spectrum, there are patients who live with a disease for 20 years. Why is that? Well, because there are probably some other variants, some factors, genetic or environmental, that influence this penetrance. And we know also that they are bioallelic variants. Those are usually very aggressive disease. The patients die in the first 10 years of their life. Very few survive to the second decade of life. We found out the carriers of ApoE, E4. You heard about this one during this symposium several times. If you are a carrier of ApoE, E4, which is the major risk for Alzheimer's disease, you have a higher chance of have that disease develop earlier and shorter survival time as well. They are environmental factors. So far we found only one on the positive side, not on the negative. The chronic exposure to steroids potentially is protective. We also found that sex and race have a influence here. Females became symptomatic in younger age. Chinese became symptomatic in younger age. So those are factors that influence penetrance, and that need to be also decided for the people who develop clinical trials. For example, do they want to have a carriers of ApoE E4 in the trial or not? So, which is a modifier of the disease course. So we also learn from the bone marrow transplant that there are studies like this one, that there are two classic phenotypes. One group of patients presented with cognitive dysfunction, one group of patients presented with motor dysfunction. And those predominantly with motor dysfunction have better chance to be treated with a bone marrow transplant. So if Dr. Spitale develops the trial, what group he wants to treat? That's another question for him to answer. Now, this was very well addressed by Dr. Lee, so I'm not going to spend much time, but it's pretty obvious the disease is everywhere in the world, and there is more mutations and more cases. And this, the first review paper that I had was 120 cases. You hear today that she has more than 1,000 cases, so 10 times more. So we also developed this clinical staging system, which is very important for the participations in the clinical trials. Here you have this severity scale that we developed specifically for the patients with a CSF1R. So we don't need to borrow another scale. This is Dr. Sundal's scale. This has been validated. So it's also important to have validation of the scale. Here is the clinical scale versus volumetric studies. So that is another way to demonstrate utility of these scales and biomarkers. Here is the fluid biomarkers. So there are already 4 cohorts, two German cohorts, and one Brazilian cohort, and our clinical cohort that we recently published. And from all this, looks like neurofilament and GFAP are emerging as a good fluid biomarkers. So neurofilament for progression of the illness, GFAP seems to be helpful in conversion from pre-symptomatic to symptomatic state before the clinical symptoms develop. So there are many others that need validations, but those two are the most important and significant, and I cannot imagine to have a trial right now without having those two biomarkers included. So where we stand right now? Well, supportive care and traditional bone marrow transplantation. So those are the options for you today. So we are talking about many future developments, but this is the decisions that the patients and us have to make when we see the patient with CSF1R related disorder. So this is our newest study. We took our first 6 patients treated consecutively with bone marrow transplantation, and we matched them with 6 natural history studies, the same sex, the same scale, beginning, and what's happened, so that all 6 patients that received bone marrow are alive. Out of these 6 patients with natural history, 4 are deceased, and 2 are total care. So clearly tells you that the bone marrow transplant is working. Not like we would like to. Some of our patients are very affected, are getting worse, but definitely the bone marrow transplant extends survival, and for some patients, a quality of life. Not for all, for some. So I don't need to spend on this. There was a lot of talk even during this session, and Dr. Spitale mentioned about possible treatments, and that's one of the strategies published by a Chinese group. They publish in this paper 8 bone marrow transplant patients, all through the traditional use. So it's a little bit misleading in this paper, but still it's a very significant development. So in conclusion, I think that the next therapeutic trial will have much easier way than the Vigil had. We and others did a lot of work to have better development of clinical trial, and I believe that sooner rather than later, we will have another trial, and hopefully this will be successful this time around, because we and others develop the tools for this success. So thank you for your attention. Oh, before I thank a lot of my fellows. Dr. Milanowski, my fellow, is also here. They were involved in many of the works that I briefly presented to you, and Dr. Dixon is our pathologist. Dr. Van Gerpen had the second family years ago that stimulated me to look for the gene for this condition. Dr. Rademakers developed the gene, and Dr. Ayala is hematologist with whom I work on this patient. So thank you for your attention.
Do we have any questions? No. Okay, well with that, we will conclude. Thank y'all for coming.